Right, well, welcome to the Digital Disruption Assessment and Treatment of Mental Health Issues via Telehealth panel and discussion. I'd like to give everyone a warm welcome for joining us tonight. And we're very lucky. We've got a very esteemed and experienced panel. We have Associate Professor Caffrey, Dr. Helen Hayden, and Dr. Cicera. I'll let him pronounce his last name because it's complex. And from the Centre of Online Health, and my name's Matthew Bambling, and I coordinate the postgraduate mental health programs at School of Medicine, and which essentially is a Masters of Mental Health and the Graduate Certificate of Mental Health, which is a multidiscipline program for people who are interested in developing specific mental health skills, particularly in the areas of psychological treatments. Although we do cover a wide range of things, including rehabilitation. And of course, we've got close links with the Centre for Online Health because digital mental health is a growing and evolving area that's extremely important. And I'm just going to hand over to the panel now one at a time and then just to introduce themselves. And we'll start with Helen, then Cicera, then Liam, just to say a bit about who they are and what they do, and then we'll move into the seminar. Over to you, Helen.
Thanks, Matthew. Hi, everyone. I'm Helen Hayden. I'm a postdoc research fellow and telehealth consultant and registered psychologist, so a few hats at the Centre for Online Health, Centre for Health Services Research. And my interests are very much my passion, I suppose, about using telehealth, using technology to increase access to healthcare for people that potentially have barriers to accessing healthcare. So one of the areas that I am doing a fair bit of work in is telepalliative care. So thinking about palliation and how sometimes it's hard to get out of the home. We can bring the technology and the health professionals into the home.
Thank you. Thank you, Helen. Over to you, Cicera.
Hi, everybody. My name is Cicera Jiripulige. Welcome to the to this webinar. I'm a academic staff member at the Centre for Online Health at the University of Queensland. My main responsibility within the centre is looking after education and training programs. So basically, I'm a teaching academic running and coordinating number of digital health, clinical telehealth courses offered into undergraduate and postgraduate level programs within the university. So these courses have been run for about over 15 years now. So over the years, we have seen that interest in the education and training has grown, but not to the extent that, you know, we can train the health workforce in this important area. So it is our conviction that since digital health is growing in many different disciplines relating to health, education and training must be a part of it. So Centre for Online Health has been very responsible for fulfilling some of the needs over the years. So certainly looking into the future, we believe that education and training in this field is going to be very important. So that's my main role at the centre. Thank you.
Thank you, Cicera. And over to you, Liam.
Thanks, Matthew. My name's Liam Caffrey. I'm from the Centre for Online Health, as well as my colleagues here. I have a couple of hats there. So I'm an academic staff member and a researcher. I'm also the Director of Technology. So I originally started life as a radiographer, so slightly different, but still a clinical background, and have come to the university after 25 years experience with Queensland Health. One of the things I like about what we do is how practical it is. Our research is focused on actual practical trials of telehealth. We work with a healthcare provider we build up or implement or develop a telehealth service, and then we assess whether it works, whether it's effective, whether it's cost effective, what works, when it doesn't. So like I say, a lot of practical trials of telehealth. So over a number of years, we've developed quite a bit of experience in implementing telehealth across a broad number of contexts. One area that I particularly like working is in rural and remote area and Indigenous health. And that's probably because of where I was brought up, which is in Nanango. So providing services to rural and remote areas has been particularly gratifying for me. Thank you.
Thank you, Liam. And we'll move right into the seminar itself now, the panel discussion. And for those who are watching us, as we progress, and if you can think of any questions you have or comments, you're more than welcome to pose a question or share a view, and the panelists can attempt to answer and reflect on the issues you've raised. And so please do that, and we'll endeavour to get through everybody's responses. But just to kick things off, we'll start with Helen. Helen, the online environment is not something that mental health professionals probably have, many would not have a huge amount of experience with that, and it's not intuitively how people imagine psychological or psychiatric intervention. So just from your point of view, is it effective? Does it work? And if it works, what makes it work?
Yeah, thanks, Matthew. Yes, well, in a lot of ways, while we have a lot of mental health practitioners and psychologists, I suppose, where it's not happening as much as potentially it could happen. Telepsychiatry is one area that it's taken off hugely. And so what we know from the research is that it is as effective as in-person consultations. So, for example, there's been a lot of research that's looked at using especially things like synchronous, so that real-time video conferencing as we're doing now. There's a lot of research that looks at that in terms of one-on-one, so individual therapy, different forms of therapy. Doesn't matter whether you are a child, adolescent, or adult, a whole range of different populations. There's been a lot of research into using mental health interventions in those sort of for those populations and using video conferencing, and it's, for the most part, it's been seen as effective, as much as effective as in-person therapy. So there's different control trials, for example, where you're comparing what happens if I deliver this sort of therapy for someone with depression, for example, and I test it against each other, either an in-person or a telehealth, and it's as effective as one another. So there's a huge amount of possibilities, and that's just purely video consultations, because there's other ranges, other ways in which mental health interventions can be used as well.
Well, I'd like you to consider assessment. That's something which people have questioned whether it can be done effectively online when people are assessing for risk or diagnosing mental health issues. What's your views on that?
Sure. So I guess like one of the rules of thumb with any sort of telehealth is that if I don't have to lay my hands on someone, if I don't have to sit up, get off my chair and come around and physically examine someone, it has the potential to be done by video conferencing. And so what we look at with things like clinical assessment, it's about very much building the rapport with the client, but also then assessing the risk. So it may not always be suitable for someone. So your first initial thing is either if you have an in-person or video consultation, you check out first, what is that person's, what's going on? What's the mental health issue for that person? How extreme are the symptoms? How regular? And at the very initial stages, depending on if you have several sessions, you'd want to maybe do a risk assessment. And so part of that is as well, is you would have a risk contingency strategy. And what I mean by that is in that first session, you would look at the support of people around them, the social support. You would collaborate with that person. You would get them to ask them, who is it in their local area? Because we're maybe assuming that a lot of this is done at a distance. Who is it in their local area, both a personal contact and a professional contact that you could get that you could find information for, so that if something happens and someone does become at risk, then you can contact those people. And your job potentially as a practitioner is to also look at the services in their area, so that you've got a backup plan. If something starts to go a bit awry, if someone's steady, stable, and then something happens, you have a backup plan where you can contact people in that area for that person. And obviously all of this is done with the person as well, and you sort of collaborate and work out why a risk plan is in place and when you might want to implement it. Does that make it clear?
Yeah, it's very interesting. Just thinking, reflecting my own experience of doing clinical work online, and there are limitations, of course. There's certain things that you might want to do face-to-face, but you can do a great deal online. And from the psychological treatments, even some of the neuro procedures like EMDR and hypnosis that can also be done effectively online. And the flexibility of the platform is just enormous. It's interesting to me that, one of the key features might be clients' willingness to have the online intervention. And if they're happy to do that, the interpersonal dimensions of the work with the client aren't that dissimilar to face-to-face work anyway, I found. Just what are your reflections on that comment, Helen?
Yeah, so we obviously, in different things that we do, workshops or whatever, and with our, as Liam said, very applied work, we have a lot to do with health professionals, clinicians, and at the outset, people are always concerned about building rapport with people and how do we get that therapeutic alliance up and happening. And so that communication is really important to, while it's very similar across in person and via video, there's certain things, simple but techniques that we need to be aware of to make it, to optimize it, I suppose, to enhance how our rapport building with the client. So it could be something as simple as making sure that you've got eye contact or looking at the camera. And so while this might seem fairly obvious, you'd be surprised at the amount of time people aren't doing that. You'd be surprised at so let's take, for example, if I'm in an in-person consultation and I have someone in the room with me, they'll see if I'm taking notes. But if they're on the other side of a video, they may not see why I'm looking away and looking something up. So it's about just simple techniques like explaining to the person at the other end of the screen, what are you doing? So there's a range of things. And I guess that's what we sort of learn when we do our courses like the Masters of Mental Health and things like that. That's the sort of things we learn to sort of make sure that we can enhance our skills to make it work.
Yes. Thank you, Helen. Jeff's raised a good point, which speaks to the issue of risk management, and Jeff's just sent us a message. For psychologists, the APS advises the inclusion of a backup contact person in the telehealth consent form, so we have someone we can contact. In the case of serious issues for the client during the session, we do have to have an agreed upon risk management strategy. So those are some of the tools that could certainly help manage risk. We have a question from one of our audience. Do you find it easier to retain patients through telehealth? So I guess they're asking about the client retention on that medium.
So I guess what we do know is that a lot of clients find it more convenient. There's a whole lot of benefits that are there for the clients. It's a very client-centered process. And so, yes, I think often you can have that engagement, but it varies. And there's a whole lot of other factors that come into play, not just the mode in which you talk, but obviously that convenience factor. You're more likely to turn up to an appointment if it's sort of at your kitchen table compared to if you're having to travel to see someone, for example. And there's a range of reasons for that as well, even confidentiality. In some ways you have if they can in bedroom. So for example, things like kids helpline or areas while telehealth isn't always, am I breaking up?
That you just froze for a second.
Okay.
But you're back now. Yeah.
So simply just, while telehealth isn't for every client, and sometimes that's where you have to weigh up the risk as well. But it means that sometimes if you've got an at-risk situation, it might actually be easier for someone to access clinical services via telehealth compared to if they had to leave the house and go and seek out some help.
Now that leads on to a question from Norm, and I think on the same topic, saying, Helen, do you see a role for telehealth in addressing the problem of stigma and discrimination into relation with people who've lived experience of mental illness?
Yes, absolutely. So there's, let's take, for example, I'll give one example. If you're living in a small rural community, I don't know whether it's going to diminish the stigma, but the reality is there is still stigma around mental illness. So if I live in a small rural community, I may not want to go and see a local clinician because word about town, and it's, you're fearful of confidentiality issues. And so again, it can in some cases increase confidentiality because you've got that anonymity when you're sort of talking to someone outside of your own community.
Yeah. Anonymity is a really interesting point, isn't it? There's a great deal, people can overcome the tyranny of distance and access problems, but there's also a greater sense of anonymity, perhaps an online consultation, or perhaps going into a clinic or a hospital and seeing someone face to face. Yeah.
And Matthew, if I can chip into the retention of patients question.
Please.
I think there's a great deal of a discussion happening at the moment is adopting the hybrid model in telemental health. So which means that the flexibility that the clinician has, having telehealth as a modality that you can use where possible and where most suitable. So that in the US, mental health hybrid model, there has been not only research, but also the adoption and integration into the practice has been happening, this hybrid model. Peter Yellerlis is one of the leaders in this area who is a psychiatrist, and he advocates this hybrid model because you get the opportunity to use both face-to-face conventional method as well as this innovative or novel method, which is telehealth. So give you the flexibility to clinicians as well as the patient. I think that gives the opportunity for retaining patients, there.
So if I understood that correctly, a clinician may then integrate telehealth as an addition or as a fundamental part of how they work with a client, and perhaps between face-to-face and telehealth consultations. Yeah.
That's correct, yes.
Yeah.
That's the hybrid model.
I was just going to say, that might be, so for example, where going back to the at-risk stuff is you might see someone in person for the first consultation, have a good intake assessment, and then work out that if that person's, depending on the degree of their symptoms or extremities of that, whether or not that person's eligible or not eligible, but suitable for telehealth. And so things might be going along and everything's cruisy, everything's fairly stable, and then something happens, which means that it's probably better then to have that person in person, those consultations in person. So that, again, as you sort of said, Sister, there's flexibility around it, hopefully.
Okay, there's a couple of points I'd like to come back to if we don't get a lot of questions, but I think we'll move on to Cicera now, given Cicera started talking, I guess, on the topic that I think is very interesting, and that's the issue of workforce development. I haven't got any specific questions for you in the area, Cicera, but what do you see perhaps has been happening in the space of telemental health and or telehealth, and where is it heading, and what can Australia expect? It's a big question, but just if you reflect on that, that would be very useful, I think.
Okay, yeah, thank you, Matthew. I think those who are familiar, those who are in the field of telemedicine, telehealth, knows that this field has been over the last 20, 30 years. And, over the years, there has been a lot of research being done into different disciplines, including mental health, to see what works, what doesn't work, and how you practice telehealth in mental health area as well as in other disciplines. And also around the world, we can see that the governments are putting a lot of money into integrating telehealth into routine practice. And, professional bodies are trying to integrate telehealth into their practices. And also there are guidelines and, different strategies. Say, for example, in Australia, we have the Australian Digital Health Strategy, which is a national initiative to promote telehealth, digital health. I mean, having said all this, in general, if you look at the integration of telehealth, digital health into routine practice has been patchy, to say the least. So it hasn't been, the uptake has been low, and the numbers that you see using telehealth is compared to conventional way of delivering healthcare is still low. So, there has been a lot of research to investigate what is really happening, because there are a lot of incentives and interest and push towards integrating telehealth into routine practice, but it is not really happening. There is a long list of, the researchers, observers have identified as problems, barriers, limitations for integrating telehealth into mainstream practice. But one very vividly stated point is the workforce readiness or lack of it. So practitioners not having the opportunity to receive appropriate knowledge, skills, competencies to practice telehealth is a major barrier. So, the expectation is that the clinicians integrate telehealth into their routine practice because it has benefits. But in order for clinicians to practitioners to understand the benefits, I think they need to be integrated in their routine education and training, that there must be a way that clinicians get the opportunity to acquire those skills and competencies. So I think that area has been overlooked over the years, and now only recently we can see that there has been a growing interest in integrating education as a component, essential component in the curriculums. Say, for example, medical curriculums are now integrating digital health. And mental health probably the way forward if we expect, and if the patients expect, that they have the option of telehealth to be utilized as a way of receiving their healthcare, mental health care. So if there's an expectation from the patients, expectations from the health system, I think the next step forward is that providing the platform for or the opportunities for clinicians to acquire systematic knowledge, skills, competencies, so that they can practice telehealth or use telehealth as a tool in their toolkit, to use telehealth in their routine practice. So that's the important part, I think, that we need to consider. I think that we are moving in the right direction within the University of Queensland. We know that MD program is integrating digital health as a part of it, and nursing curriculum. So there's a growing interest and visible measures to address this growing need. Thank you.
Yeah, that's very true. And I've had some questions about the Australian context, but we've got a few questions coming in from our audience, so I'll move to them. These are out of order, and I'll start with the one most relevant to what you said. And from Norm, Anne's actually asked a good one, which we'll come back to. Norm says, Cicero, telehealth seems to have grown very quickly as a result of the coronavirus. At the same time, mental health problems have grown quickly as a result of COVID. It's expected this will continue after the virus is stamped out as far as possible. From what you were saying, Australia is not really ready to cope with the increased demand. And I guess if so, how long do you think it'll be before Australia comes up to speed to meet the current and emerging demand for telehealth?
Yeah, interesting question. Yes, certainly those who are in the field of telehealth has noticed that there has been a massive increase in the interest of telehealth from practitioners as well as healthcare consumers, because of the obvious need for utilizing new models for receiving and providing care. So the coronavirus situation is a good example. So in terms of readiness, certainly, and I'm sure Liam and Helen can chip in here because they have been doing some workshops, and also, you know, they have practical experience in doing that. So, but we can see the hasty measures taken by the health system as well as the government probably to address this problem, knowing that this is going to be the way forward. And you can see some relaxation of reimbursement for telehealth consultations being implemented in a very rapid way. So that's a very good example to show that, you know, from government perspective, it appreciates and understands the need for growth in telehealth and promotion of telehealth. So the incentives for doing telehealth has been provided by monetary rewards, you know, by giving reimbursement. That's one example. So I think this is a good example that in the future, as we go forward, probably coronavirus situation has given us a good indication that, you know, the telehealth is there to stay, you know, for long run.
Yeah, look, I'd agree with that. It's certainly my experience has been that COVID, I guess the mixed, if there is an upside to it, it's certainly established telehealth as being a really important strategy. You know, perhaps governments are a little confused at how to value that, but that feeds on, I think, to a question asked by Anne. Anne's asked a couple of questions, and Jeff's got one that's following on as well. Anne says, what do we think this is open to everybody, what do we think the likelihood of reimbursement levels for telemental health being on par with face-to-face consultations? As it would appear that equitable reimbursements are still one of the remaining barriers for access. And Anne's talking about this as an access issue. You know, if providers aren't being paid sufficiently to provide a telehealth service, if it's not seen as equivalent, then they're less likely to provide it. What are people's thoughts on that?
If I can just jump in there, Matthew, I will say that specialist service, psychiatry services are actually reimbursed at 150% of an equivalent in-person consultation for Medicare. So I'm wondering if Anne's question arises from the fact of the mandate for bulk billing and the schedule fee that was available, and how that was nowhere near commensurate with the APS recommended fees. And I think the aim is to have it as an equivalent. And, you know, the foundation of a good funding model is that the effort and the reimbursement should be commensurate with the effort to undertake a consultation. So whilst the specialist fees were increased, there was some recognition at that stage that it was a bigger effort to undertake telehealth. I think some of the learnings we're getting from at the moment is that it's of a similar level of effort. The investment in equipment is small, and that's how we would like to see it at an equivalent rate. And I do believe that they have actually relaxed the mandate to bulk bill. I'm not sure if anyone can.
Yep. Yep. Yes, and my understanding in the psychologists at least has been relaxed. Liam, following up on that, Jeff just sort of made a comment, I guess it's a question too, that he's concerned that the federal government has limited telehealth post-COVID-19 in September. And does the panel see any possible changes to this funding model?
Yeah, I think the government has no doubt taken a risk aversion approach to actually funding telehealth, and this is across the board. The initial introduction of only item numbers for specialists where they needed a GP referral, and that GP referral acted as some way of limiting the amount of services. They also had the geographical constraints, which Jeff recognises there. If it's any consolation, the Australasian Telehealth Society put in a submission to the Medicare review to remove those geographical constraints to MM 4 to 7. So whether that is considered by the reform of the Medicare, but it's something I'd like to see. But I think there's other ways that they can look at actually constraining the number of services. I talked about the GP referrals, but GP referred mental health plans for metropolitan patients is certainly one step of actually being able to provide services to patients that reside out, in different geographical areas to the MM 4 to 7. But I think for the foreseeable future, we will still see geographical constraints because I think they will still continue with their risk aversion approach.
Look, I think that's quite a likely scenario as well. Anne's actually posted the question, which was designed just for you, Liam. And so Anne would like you to comment on how can telehealth, digital health software developers involve mental health professionals in new implementations and make sure that digital is truly supporting the delivery of service instead of adding a layer of complexity to their clinical practices.
What we're seeing, Anne, is we're now seeing a third and fourth generation of software, and a lot of that has come about from the COVID and the huge uptake and the feedback the software developers are actually getting. So if we think of our first couple of generations of video conferencing software, we had the Skypes, which were the commercial grade ones, and then we had commercial business providers, the Zooms and the PEXIPs. Now, what we've seen now is there's a huge amount of practice management software applications that are actually embedding video conferencing as an option for their practice management software over their electronic medical record. And that's in recognition of the fact that it's not as separate to practice. And the fact that it's actually embedded allows you to streamline some of the processes such as scheduling a patient or contacting a patient or billing, as well as having some of those clinical functions like questionnaires or assessments being actually built in to the content channel of those. So I think we've made huge leaps and bounds very, very quickly, but it's a case of actually speaking to your vendor, your practice management software vendor.
Liam, while we've got you there, I'd like to ask you a few more questions just based on your expertise. What are the key features to look for in a video conferencing platform for telehealth?
Yeah, okay. So I think there's probably 4 key features that I'd look for, and probably I think the most essential is a waiting room or a virtual waiting room. Now, a virtual waiting room has a couple of functions. First, it is if you're not there to take a call, you don't want your client, to be like a phone call, have a missed call. So that having a waiting room allows a person to actually be shown in and part of the waiting room, straight into the waiting room, and you can see the clinician's name or some bespoke message that says they're available. And I think that relieves a lot of anxiety with the clients or patients. Secondly, having a waiting room stops intrusions. So we've probably heard about the phenomena of Zoom bombing, where people break in or hack into a consultation. And if that's between a clinician and a patient, that would be considered a serious breach of privacy. So like I say, one of the first things is the waiting room. The second thing is encryption. And I think it's just so understood. And this is why I think that if we defer to an actual health video conferencing platform as opposed to a business one, they have this privacy view that we as clinicians want to have. So there's a number of parts to that. Like I say, intrusion protection, waiting room can do that. But there's other ways to prevent intrusion protection, such as being able to lock down a consultation to 2 people, or limiting the number of people that can attend, or password protecting it. The other part is encryption, that you need strong end-to-end encryption, and that's so that the audio and the video can't be intercepted as it travels over the internet, or can't be understood if it is intercepted. We've recently done an audit of video conferencing platforms, and it was very pleasing to see that of the 16 platforms that we audited, they all supported strong encryption. What was less apparent was that this concept of end-to-end encryption, that's where only the sender and the receiver can decrypt it. There was a number of vendors that as the traffic travelled across a series of servers between the sender and the recipient, that they could decrypt it at each of those server hops, which is not malicious, but it does represent a security, security problem. The other aspect of security and privacy is where the servers are located. Those ones that are travelling on the hops, it is best that they are actually located in Australia. That's the best practice for privacy and security. So we need to look at those. I think the other thing too is that you need to have a really simple interface for the patient. The simpler the better. So the way that you joined this meeting today was by clicking on the hyperlink. You don't want a video conferencing platform where your client or your patient has to register to create a username and password. They have to install software. And for this reason, there's a technology, WebRTC, or Web Real-Time Communication, which allows video conferencing to run inside a browser. So there's a number of vendors that support that WebRTC. And that is inherently more secure because the communication is from person to person. We know it's secure. And probably the final thing is that I'd be looking for a cloud provider. And having a cloud provider creates a really cost-effective way for a small to medium practice to have an entry point into telehealth without having to buy their own equipment, their own servers. And you can get really cost-effective cloud video conferencing providers at a price point, sort of $20 to $30 to $40. So I think they're really, really, really affordable. So they're the 4 things: waiting room, security, a simple interface for a client, and a cloud architecture.
Yeah, that's very interesting. Are they, I guess, in just terms of ensuring security, are they the key things, or do you have any further tips for people?
Look, there are a couple of further tips. Some vendors have it automatically, security automatically configured. And some you actually have to do some configuration. So I think there is a need to do some due diligence on the documentation that comes from the vendor to ensure that it is actually configured properly. Like I say, intrusion protection, you've got to use one or more mechanisms for that. Waiting room is a great one. If you don't have waiting room, there are other tips that you can do, or a combination of those. I think there's other things too, where there's a few products have some flaws, in that we talk about, the audio and the video part of a video conferencing platform, but a lot of providers use a content channel, and that's a data channel, like I said, that they can, provide assessment questionnaires, or they can provide instruction sheets to the patient, or that, they can use it for various other functions. So I think you also do need to check that content channel is secured as well.
Jim has made, you probably can see it in the comments, Jim has made a comment that it's encouraging, but were there any encryption options available for free services, or was it really restricted to the premium services?
No. Like I said, all the video conferencing platforms that we audited use strong encryption. Okay, so encryption technically is not difficult to implement, and it's not difficult to implement strong encryption versus implementing weak encryption. So no, there was definitely encryption that was available on free platforms. like I say, it needs to be a combination of strong encryption and also end-to-end encryption as well. So you need to actually check both those parameters.
Yes, Gian comments, Australia's current internet infrastructure is behind most countries in the global north. Could this negatively affect telehealth in Australia in the post-COVID era?
Yeah. Look, I think there's no doubt, and it surprises me in two areas about the lack of connectivity, and that can be the lack of infrastructure, or but also the cost of providing infrastructure. And there's a lot of people that simply, maybe have a mobile phone with a small data plan, and to actually ask them to use that up for a consultation and have nothing left for the rest of their prepaid time. So yeah, infrastructure, and it's really surprising that we think it would be more remote areas that have poor infrastructure, but we've had experiences with some Brisbane suburban areas that are actually really poorly serviced. Highly populated areas of Brisbane that are really poorly serviced by internet infrastructure. And so it is an issue. In terms of mobile technology, certainly 4G was very sufficient to do video conferencing, 5G, whereas 3G was less. We do know now that because of the broadband that everyone in Australia is supposed to have access to a broadband, even if it's by satellite. So the Sky must that. But really high latencies on satellite connections can make it difficult to actually do video conferencing.
Thank you, Liam. And there's lots more we'll ask you, but just want to move to a question by Anne, and it's open for everybody. And she's noticed we've been primarily talking about telehealth and the role of video links, and of course it's much, much bigger than that. And she's interested in hearing about where it might include digital online CBT programs, for example, or apps, or support groups online, those types of things. What would people like to comment on their experiences of using those and how they're used?
Anne's right, there's a whole range of things. I mean, one of the most common forms that is being used, I'd say, is the video, which is why we probably focus on that a fair bit. But yep, she's totally right. There's apps, especially in terms of health behaviours and behaviour modification stuff. And a lot of the research looks at CBT and how that can be used in things like text messaging as well. So what we find with things like apps or the text messaging is often the rule of thumb in a way is if it's based on something that's quite evidence-based like CBT, then you're more likely to have an efficacious intervention there as well. But there's things like online forums. So depending on the situation, if it's something maybe that's a bit of a stigmatized issue, then someone might really like that anonymity by going onto online message boards. But part of the issue with that is that if you're relying solely on peers to normalise situations, for example, or support you, that's obviously got risk in there. So often those things need to be moderated by a health professional. But there are a range of other ways in which we can sort of use interventions for sure.
Yes, it's very interesting, the creativity that's gone into delivering mental health treatments, using apps. Some interact, some can adjust their responses to suit patient input. There's a lot of really interesting research going on in that space. Yeah. Okay, and we'll just might swing back to Liam again quickly. What I'm interested in asking you, Liam, is how can a clinician reduce video conference fatigue?
Yeah,
that's a pretty normal phenomenon of people do a lot of online consultations.
Yeah, I've actually been following a lot of Twitter conversations. I've got some filters to see what's going on in the Twitter sphere about telehealth. And that's one of the things that a lot of clinicians are complaining about, that there's this sudden huge increase in video conferencing, and they're trying to compare it to their day-to-day practice or their in-person practice pre-COVID. They're saying they're exhausted. And there's very plausible reasons for it, in that if you have a poor connection or poorly optimized, for example, poor lighting or noise in the background or various other things like that, you're spending a lot of cognitive effort filling in those gaps in the communication that don't occur in person. So it's a really important thing to actually optimize your video conferencing. Not so much in terms of your platform, but three things. Your internet connection is really important, so you've got some options there. If your internet is you have these problems like freezing or pixelation of the images, or loss of small parts of the video, or loss of small parts of the audio, that indicates you've got a network problem. So things like upgrading your plan. So you go into a higher NBN plan or a higher cost plan, is one thing that you can do. Moving from a domestic plan to a business plan. So most of the ISPs have a business plan which has higher quality of service. So that's another option of optimizing it. If you're going into your clients or your patient's home, ask them to ask their family members to turn off their Netflix and turn off their PS4 gaming. Most networks are contention based, so removing those competing internet applications will increase the amount of bandwidth that's available, for video consultation. In some areas where there's poor connectivity, and I'm thinking about some of the work that we've done in some of the Indigenous health services in Western Queensland, we actually installed a second internet connection. So their existing connection was used for their normal internet activity, web browsing, their email, but the second one was dedicated for video consultations. And that was an extreme way, a costly way of getting enough bandwidth to do a video consultation. I think you've also got to look at other things as well. Your environment, having appropriate lighting, making sure you're not backlit, you're lit from the front. And you want to see non-verbal communication. You want to see facial expressions and things like that. So lighting is one. Acoustics is really, really important. Really simple stuff like shutting the door. Trying to do it in a room where there is some softening, some acoustic softening. So a carpeted room, as opposed to, say, a clinic room that's just got a hard linoleum floor and hard surfaces where you get that echoing. And it may not be apparent to you, but it does transmit a very large amount of noise to the far end. So think about your acoustics. And then there's some behavioural things, and I think it's up to you to get it right, and for you to coach your client or your patient. Now, if you're well framed in the picture here, like you're talking to me, you want to see what I call the newsreader view, head and shoulders. But if you've got clients that are sitting so far back from the camera that you can't actually see them, or they're out of range of their actual microphone, that's you coach them. You say you will need to sit close to the camera. And if there is ambient noise going around, encourage them to actually use a headset. The headset that you can use for your mobile phone conversation is quite appropriate for video consultation as well. And the use of a headset, does go a great way to improving the audio quality. So just a few tips. It's there's a lot of ways. So just try and optimize your actual video consultation experience, and that will reduce your fatigue because you're not spending that cognitive effort trying to fill in the gaps.
Thank you, Liam. We have a few more questions, which is great, and we'll open up to the whole panel. Just indicate if you'd like to speak. Lisa's asked, do you have any examples, I guess, any knowledge of the use of telehealth for people with disabilities and what additional assistance they might require? Thinking things like autism, deafness, cognitive impairment. I'll throw in things like that, like cerebral palsy and some of the other developmental disorders as well. Is anyone aware of any work in that area?
No.
Okay, Lisa, you've stumped the panel. Well done. Yeah. Look, Sister and I are aware of some work in the cerebral palsy area with the specialised video machines, which can also allow physical assessments. They have all sorts of bits of equipment built into them to allow a remote practitioner to do physical assessments as well as mental health assessments. So there is work occurring in that area. So I'd like to move on to Jeff now, and he has a question in relation to the ethics of recording sessions, and he says he doesn't do it, and he asks his clients not to record. What do the panel think about recording therapy sessions online?
If I may, so part of, and someone else alluded to it earlier, part of that informed consent process that happens at the beginning is when you'd have those discussions. We have known of cases where you are talking to a client and then there's a bit of a shadow in the background, and it's ended up being that it was someone in the background recording. So you don't want it to get to that stage where you are being recorded unknown and vice versa. So it's that transparency when you're doing informed consent in that initial session. And that's when you outline the rules there. And I would basically say you would err on not recording. I can't see if you're doing adequate note taking, you wouldn't want to record, but obviously it all has to be informed if you are going to record a session, and vice versa. You relay those expectations to the client that no recording happens unless there's consent from whoever the participants or the parties are involved.
I'd echo that, Helen. I don't think there's any profession that promotes the recording of video consultations.
So that's interesting. That sounds like an industry-wide standard, Liam.
It does, and
yeah.
There's a lot of practice guidelines that are written by profession-specific groups, and to the best of my knowledge, none of them, like I say, recommend recording the video consultation. And as Helen says, in lieu of that, you know, what you need to do is keep accurate and contemporaneous notes, the same as you would do for an in-person consultation.
Well, thank you. Norm has a comment and question, and he says that he thinks that Beyond Blue has online forums. With the rapid growth of mental health apps, he's concerned as to the coordinators, the facilitators, and even the legitimacy of some of the apps. So I guess that's an issue of app quality and who's designed them. The Australian Health Quality and Safety Commission is currently developing digital standards for mental health, digital health. How difficult does the panel think it will be to monitor such standards, and how effective do you think they will be? I guess the other question in there is, how would they actually do it?
So I've got some insight into that, Matthew, in that it's not just for mental health, it's for all apps. And we've basically got a fairly unregulated market with some 300,000 health apps being available now, and clinicians do not have any idea of how well that how efficacious or how even safe they are. So work that's being undertaken that was driven out of Queensland Health and is now largely being adopted by the Australian Digital Health Agency is to have a rating system of apps. So if somebody wants to use an app, the idea is that we'll end up with a repository of safe apps that clinicians can use. And so you look at the function of it, whether it's information only or going down towards an intervention. So that's on one scale. On the other one, you look at the disease process. So if it's something like some low acuity disease, and going up to maybe cardiac disease, which is that. So it's a risk-based approach. So green, red, yellow. Green, the developers can actually do a self-assessment. The yellow and the red need to do have an external assessment by a statutory body, which could be someone like Queensland Health or New South Wales Health or WA Health or any of those statutory bodies there. So basically, if somebody wants to use an app, a clinician has to recommend it. It needs to go through that audit process. If it passes the audit process, it goes on to a register there. So there are ways, and this is what's, it's largely following the process that was done by the NHS, but just the sheer size of the app market is going to make it very, very difficult. And then you've got these questions, like about if the version of the app changes, do you have to redo the process? And if it, like I say, referred by a clinician, well, you've got a lot of clinician entrepreneurs that are developing apps. So is there some conflict of interest, and how do you address that? But it is work in progress. And I think there are some mature ideas about how to assess it. Thanks, Helen.
That's great.
add to that one? Sorry, Matthew, is that just to quickly, in the meanwhile, while it's so unregulated, there's been some work done on the MARS, which is a mobile app rating scale. And so that looks at something that clinicians can do in the meanwhile. If you've got an app, obviously you want to explore it yourself before recommending it to any clients, before using it. But the MARS scale looks at things like how it has 5 dimensions on it. So it's like, how engaging is the app? What's the functionality of the app? How aesthetic? So, and information, that is it evidence-based information that it provides? So it doesn't look obviously at the efficacy. That obviously takes a lot more research in terms of one app, but it is it's a fairly, I guess, way that clinicians can actually use it to see any apps that they might want to have some more sort of more objective assessment on.
Yeah. They're great insights. Look, we're nearly out of time, everyone. We've got questions keep coming, which is great, and I'll read them out, and if people have a quick comment they'd like to make, that's fine, and then we'll just move to the wrap-up phase. Terry was asking whether telehealth models can be used to supervise students on placement, and particularly supervise them conducting mental health assessments. And I thought that was a great question, because that potentially is something that would lend itself very strongly to telehealth, but it brings in the dimension of someone observing an online process with a person doing clinical assessment. Any quick thoughts on that to the panel?
I know that it's been done a lot in other allied health disciplines, and that, particularly at University of Queensland in the Tele-Rehabilitation Centre, that they've got the infrastructure for not only students, but a clinical educator to observe a student interaction via telehealth, the interaction with students' interaction with a client via telehealth. So I'm not sure in the mental health area, but there's certainly some foundational work being done in other allied health areas.
To me, it's supremely sensible to do some of that, because not only are we able then to supervise a student, but they actually get specific supervision in their telehealth practice and the dealing with the idiosyncrasies of the medium. And I think that's a very, very useful thing to do. Yeah. And sort of wonders about the safety standards include technology safety ratings, along with clinical ratings, given the sensitivity of data in vulnerable populations.
Yeah, absolutely, no doubt, Anne. Privacy and security are very, very important, and stability of the platform as well, where the data is stored. The same privacy principles that apply to video conferencing traffic being routed offshore is where this data is stored. If it's collected by an app, whether it's stored actually on the smart device, or whether it's stored somewhere in the cloud. So yeah, there's a lot of assessment done, technological assessment done, as well as clinical.
Okay, well, thank you for that. And I think just to wrap it up, we'll just maybe a minute, I'll just give a bit of an overview, and people can jump in about the relationship between the Masters of Mental Health and the Centre of Online Health. If you've enjoyed tonight and you want to do a Masters of Mental Health, well, UQ at Medicine has the one for you. And it's a great program, and it provides training and evidence-based treatments, but we have a strong relationship with the Centre of Online Health, and it's so you'll see Liam or Cissa or Helen actually giving some lectures on the topic. It's even possible for students who wish to do some of their placement time, they can do an immersion at the Centre for Online Health as well. And so it's really on the cutting edge. And I can say with my experience of working with the Centre for Online Health, it's a first-rate facility. And I hope you got a sense of that tonight. Is there, just turn over to the panel, any closing thoughts or comments from Cicero?
Well, I think basically in terms of education and training, certainly that which is my area of interest, and we can see that is expanding, and Master of Mental Health program is now is been undergoing a lot of refreshment and revampings. Probably this is the right time for the incorporating some digital health aspects into the Master of Mental Health. So this is what is happening. Certainly, as you said, that over the years we have had a number of students taking placements at the center, understanding how telehealth works in their mental health service delivery. So certainly that opportunity and collaboration is there. So certainly you're welcome to your continued collaboration. Yeah.
Right. Look, thank you, Sister. Because we're out of time, I won't be able to ask the other panel members, so Sister will have to speak on behalf of the Centre for Online Health, but I'd like to thank everybody tonight for coming along and being part of this. I think it was a fascinating conversation. I'd like to thank our audience too for your great questions, and it was very engaging. And on that note, we will say good night. So good night to all.